Hello, my name is B Longmaid. I'm a physician in the Boston area in Massachusetts in the United States, and I'm happy to be joining you today to speak at the Health Crisis and Education Conference of HEDRA regarding communication about the COVID-19 pandemic. What and whom are we to believe? Let's start with an overview. Accurate and trustworthy communication in healthcare is essential for optimal care. Whether at the individual patient or societal level, this foundational component of care has been significantly challenged during the SARS-CoV-2 or 219 worldwide pandemic. Conflicting communication regarding the pandemic has left much of the world confused and unsure of what or whom to believe. Time and truth come together on the horizon. Let's keep that in mind. I'd like to start out with an idea that finding truth is really a search that we all engage in all the time. And we need to understand that we assume that truth is there in certain domains of our lives, but isn't always the case. We think of media. Is media truthful or is it slanted? We think of science and technology. We'd like to believe it's truthful, but it may be incomplete. And because there's an incomplete narration, we might not know the full truth. The social environment, we know, is complex. Leadership, we'd like to believe, is on a higher moral plane, but we know that isn't the case. And we understand the influencing factors in the milieu. We know there is bias, there are agendas, politics, economics, and plurality and tribalism. All of these can influence how people, through different lenses, see the world and see truth as they know it. Oftentimes these are conflicting when we meet and have discussion. And as challenging as 2020 has been and the first part of 2021, we need to recognize that there are coexistent challenges in the time of the COVID pandemic. Climate changes and crises, floods, fires, volcanoes, other major natural and man-made crises. We have a significant portion of the world's population having food, water, or shelter and housing insecurities, massive poverty, racism and violence against ethnic and racial groups around the world, migration and economic disparities, all influence the way that we see the world and the way that we deal with the coexistent COVID pandemic. In this presentation, I will explore some of the factors contributing to this confusion and uncertainty, from divergence in agreement on the scientific findings, or what we always traditionally thought of as facts, to unintentional and perhaps even intentional efforts to alter public perception regarding how best to respond to the pandemic, both individually and societally. I'm going to start by just reviewing for you what we do know, or we think we know. We know that the SARS, or the severe acute respiratory syndrome, or COVID-2 virus, also known as COVID-19, was initially reported out of Wuhan, China in December 2019 by a team from the Viral Institute of Wuhan. Rapid genomic sequencing, which they were able to do, showed that this was a beta coronavirus with a single strand of RNA of approximately 30,000 base pairs, which coded for 10 genes producing 26 proteins. Including in the proteins are an RNA polymerase, which allows the virus to copy its genome. There's a proofreading exonuclease, which stabilizes the genome to reduce mutations, which reduces the mutations about tenfold by comparison to other more common viruses, or other common viruses such as the flu. There's the spike protein, which we know about 90 on each particle, as well as nuclear protein that packages genome, and two membrane-bound proteins. It is one of the largest genomes of any coronavirus, most of which are in the 14 to 15 kilobase pair range. The infectivity that has been observed suggests that each infection generates 2 to 4 additional infections unless masking or physical distancing or other countermeasures are being used. There is a latent period after infection of about 3 days, followed by a maximum infectivity of about 4 days. Curiously, the patients are shedding and spreading the virus for 2 days before they're symptomatic. This creates a problem because patients are out interacting with the world, not realizing that they are infected and shedding virus, infecting other people. The diagnosis is often made 5 days after symptoms begin because it is for the patient to demonstrate their symptoms and to report their symptoms to their physician or care provider. And that is about 10 days after they're infected, and actually after the peak infectiousness is over. Interesting, many people, including children, youth, and young adults, may be asymptomatic. It's been estimated up to 50% have no symptoms. And the issue then becomes the uncertainty regarding whether or not they are serving as a disease vector, and therefore how infectious is this virus. We know it certainly is not as infectious as something like Ebola. As a respiratory virus, the particles are aerosolized. They are estimated to be approximately 0.1 micron or 100 nanometers, and that means that an N95 mask has about a 99.5% likelihood of stopping the virus. The particles will travel 6 to 20 feet depending on how they're spread through a sneeze or through talking or through shouting before they fall. That's why there is a recommendation of at least a 6-foot physical distancing between people to reduce that percentage that they may see from people next to them. Within infected individuals, there are a number of concentrations between 1 million and 1 billion particles per nasopharyngeal swab, between 10,000 and 100,000 particles per throat swab. So you can see the nasopharyngeal swab is more effective. There are a fair number of particles in the stool, which is why some towns and locales will test the sewage to determine whether or not there is infection within their community. Sputum, interestingly enough, has between 1 million and 100 billion particles per ml, which is why a number of places have gone from testing the nasopharyngeal swab to testing the sputum. The spike protein, which is approximately 90 per particle, attaches to the angiotensin converting enzyme receptor on lung, renal, cardiac, and hepatic mammalian cells, and that's the way they get into the cell. This is a slide from the British Medical Journal in 2020 and is a very good diagrammatic representation of what happens. When the particle comes into contact with one of the mammalian cells that has an ACE2 receptor, the spike protein binds with that, and then the host's transmembrane serine protease 2, which is a cell surface protein, strips away a part of the spike protein and allows the particle to be incorporated within the cell, usually within approximately 10 minutes. Once incorporated, then the virus, which does not have a capacity to exist on its own, then the membrane is broken down and the RNA polymerase goes to work to replicate the genome through the use of the host cell's protein producing mechanism, as well, or the RNA producing mechanism, as well as the protein. Once those are created, the new genomic material is encapsulated through a membrane, and it is released out into the rest of the environment. It does not cause a cell to burst, which would cause those cells to die, but they are released, and it continues on a fairly frequent basis, about a 10-hour cycle for this to occur. This is a demonstration of the sequence from initial infection, as you can see here. The pre-symptomatic phase, approximately 5 days. The patient is starting to shed virus at this point in time. Viral genome is being expressed by the patient, and not only elsewhere in the body, but to others through aerosolized droplets. Remember, the patient is not yet symptomatic, and they start to become symptomatic after that shedding is already occurring, so that they are continuing to spread the virus. It's a very effective agent to do this. And the patient has a range from mild to moderate illness, particularly if they're young or do not have any comorbidities, and the risk for more severe illness, which we'll get into, has to do with the comorbidities and likely host compromise. As you can see, the time frame on that is roughly 5 days from initial infection another 5 days before they start to show symptoms, and within 2 weeks they can be quite ill. Let's take a moment to look at how the SARS-CoV-2 virus compares. It is a coronavirus, as I said, and it's very similar to the SARS-CoV-1 beta coronavirus in the sense that it is the same general theme and the same general symptoms. That was described in China in 2002, and it also had an intermediary host through cat-like civets. MERS, which is the Middle Eastern Respiratory Syndrome virus, is also a coronavirus, was found in Jordan, or first presented in Jordan in 2012, and they believe it came from bats to humans via an intermediary host of camels. Fortunately, that was a relatively limited outbreak. A number of common colds are coronaviruses. Some are influenza viruses, and the more common ones are 229E and 0C43 strains. Interestingly enough, COVID-2 has a percentage genetic sequence similarities to COVID-1 of about 80%, to the bat coronavirus, which is what people have talked about possibly where it's coming from, about 96%, and the other possible intermediary animal from which humans may have received it, the pangolin, which is a delicacy and eaten in certain parts of Asia, approximately 91%. Interestingly enough, however, no species with a host virus similar to SARS-CoV-2 has been found to date, despite aggressive search. And this raises an interesting question in terms of the origin of this, if it was from an animal reservoir via an intermediary host, or if it came from some other event, and we'll get into that momentarily. Unlike those other viruses, however, coronavirus SARS-2 has been a worldwide pandemic. And we'll talk about that in just 1 minute, but we want to compare with the last major pandemic, which was actually a little over a century ago, the Spanish flu of 1918 through April of 1920. People don't remember it so much because it was right after World War I, and that kind of overshadowed it, even though this killed a lot more people than World War I did. It is an H1N1 virus. It also is a respiratory spread. It was a slow global pandemic because we didn't have the rapidity of spread because of travel. Airline travel means that in this day and age, people can be anywhere around the world within 24 hours. And if they aren't aware that they are ill and they're shedding virus, they can be shedding it throughout their travels for several days, which means that within a very short period of time, the virus would spread from wherever it first presented, someone getting on a plane, someone getting on a boat, whatever, and spread. And by the time that it's recognized, that means that in all likelihood, it has gone quite broadly, and that's what happened. As of July 4th, 2021, according to the World Health Organization, been 183 million cases worldwide. The number of deaths, which is approximately 4 million deaths. I'm sorry, it was a typo there, including several surges and mutations. The Economist magazine did a modeling of this and said the real estimate of deaths is probably 2 to 3 times that, and as many as 2 to 7% of the number of people having it. How does that compare with the Spanish flu? Well, keep in mind the Spanish flu, there was very little known about it and very little that could be effectively done. Approximately 500 million cases, or approximately a third of the world's population, and 20 to 50 million deaths, or 4 to 10% of those who had it. And so the COVID SARS-2 is not as severe as the Spanish flu. So far hasn't lasted as long, but it has still been quite significant. We have not had the same number of deaths, but it is not a simple self-limiting process like so many other viruses, including colds. We need to talk about how early containment and treatment is critical to controlling a pandemic of this type. We know that N95 masks and physical distancing of at least 6 feet are critical. We know this from epidemiologic proof of containment. Isolation and quarantine, if we think someone is sick or has been exposed, even if they don't show symptoms, quarantining them will reduce the likelihood they're going to be a vector to pass it on. The other issue is exposure tracking and monitoring and containment that way, and of course hand washing. The issue of national and local lockdowns, limiting travel, gatherings, social life events, and so on, has been challenging for many. Closing schools, restaurants, and bars, for example. One of the early countries that was severely affected was Italy. A number of people coming to work in Italy from China, and anticipating that they perhaps brought the virus with them. And even though Italy attempted to limit and lock down social involvement, the fact that you had often several generations living together in close quarters in certain parts of Italy, with young adults going out and continuing to have social engagements, bringing back the virus even though they weren't sick, and having the elders be affected, and that was felt to be the way by which so many people were exposed and got sick so quickly in Italy, particularly in the northern section. The early surges had an unclear pattern. The severity started to be noticed that it was related to age and a variety of comorbidities. And the respiratory compromise and diffuse inflammatory reaction was what was really so striking. Treatment protocols, initially not clear how best to do it. Rapid iteration of protocols were coordinated globally via websites. And as people attempted different maneuvers, different protocols, they started sharing those on websites rather than writing them in papers that would normally take a year or longer to go through the publication process. This was a recognized process by which they could share results much faster than the traditional means of standard paper publication. Many medications and other interventions were championed, but not all demonstrated to be efficacious or safe or widely available, and we'll get into this more in just a minute. Ultimately, the way that a pandemic is contained is through widespread immunity via vaccination or natural herd immunity acquisition. Unfortunately, we can't wait for natural herd immunity acquisition because of the large number of people who may be quite ill or die while this is occurring. So the vaccination route is the critical one. It is timely and curious that technological advances that had been looked at for the last 10 years or so and looked at primarily for veterinary purposes, that of mRNA technology, was an opportunity to test out this new technology. And they were able to create a mRNA vaccine within months of when the genome was sequenced, and then develop it and test it. And it was a much faster rollout than the traditional means, which would normally take longer. The challenge of this, of course, means that the vaccine wasn't tested to the same degree and duration that the more traditional vaccines had been tested. The vaccine rollout also was uneven. Countries that were funded the developments, such as the United States, received the first doses. They felt that they purchased them accordingly. The vaccine, 70 to 95% effective in preventing severe complications or death, which was the primary measure, not necessarily did it prevent infection. Interestingly enough, of course, is that we found that probably does prevent infection, but that wasn't what was initially evaluated. It is estimated that approximately 70% of the world's population must be vaccinated or have had the illness to achieve herd immunity, and that is necessary to slow or ultimately stop transmission. And until the whole world is vaccinated, we will continue to see pockets of mutation, which will bring about potential reinfection of those who are already vaccinated or create bigger challenges to those who are not yet vaccinated. As of this recording, the Delta variant is now the dominant variant. It's more infectious, perhaps not quite as dangerous, but it has become the most common one. And although it is contained relatively effectively by the vaccines, it is still at risk for people who have chosen not to be vaccinated. If we are to look at the containment and the exemplars and others, what have we learned? Well, we have Taiwan with 24 million people having, this was in early June, 2,000 cases, although they were now having a new surge, and only 12 deaths out of 24 million people. South Korea with 51 million people had 132,000 cases and only 1,900 deaths. China with 1.4 billion people had a significant lockdown, had 102,000 cases and 4,846 deaths. There are some people who have challenged the accuracy of those numbers. By comparison, Italy with 60 million people has had over 4 million cases, over 125,000 deaths at this point in time. The US, with 331 million people, has had 33 million cases and over 600,000 deaths. India, 25 million cases and 280,000 deaths. Brazil, with 213 million people, has now had over 18 million cases and over 500,000 deaths. I want you to look at that and just recall that the United States and Brazil have had the largest number of deaths and infections. And think about leadership and messaging that went in those countries compared to others. The delayed or inconsistent use of masks and social distancing directly correlates with surges and national and local leadership issues, as I've said. Surges cause overwhelming of available resources, including personal protective equipment, ICU beds and ventilators, oxygen, as well as the personnel to help care for the patients. Unfortunately and sadly, certain parts of India and other parts of the world have had fires in hospitals or fires in oxygen manufacturing or vaccine manufacturing centers, which have complicated the availability of certain critical resources. And unfortunately, because of the number of institutions overwhelmed by COVID patients, a number of critically ill non-COVID patients may be turned away and possibly not survive because of this. What have we learned about the risk factors associated with severe disease, risk, and mortality? Well, we certainly know that older age is associated with increased risk, particularly over 70. Male patients, hypertension, those with cardiovascular disease, COPD or emphysema, diabetes, obesity, and malignancy. Also, those who are Black or Latino seem to have a higher propensity for severe disease. Presentation of fever of over 39 degrees centigrade on admission, dyspnea or shortness of breath on admission, oxygen level below 94% on room air at sea level, and higher SOFA scores, which is sequential organ failure assessment, which is a 6-organ system assessment looking at risk, including blood, liver, kidney, neurologic, blood pressure, and hemodynamics, which is really cardiac, all factoring into putting you at a higher risk for significant disease and mortality. Laboratory markers in patients who are at risk: neutrophilia, which is a decrease in the white cells, lymphopenia, elevated lactate and lactate dehydrogenase, elevated C-reactive protein, which is a measure of inflammation, elevated ferritin a similar way, elevated IL-6, which is interleukin-6, which is a cytokine that triggers immune inflammation reaction, elevated ACE2, and elevated D-dimers. One of the things that has been distressing is that a number of patients who have been ill have demonstrated abnormal clotting factors and vascular inflammation, which affects all organ systems and not just the lungs. Most patients who get infected will have mild symptoms as their immune system and the T cells eliminate the infected cells before the virus spreads, but in those at increased risk, there's an aberrant host response leading to severe inflammatory reaction, vasculitis, and clotting disorders affecting multiple organ systems, as I said. So the current NIH recommendations, and this was updated very recently, is that outpatients with mild symptoms and no risk factors, you manage them symptomatically. Fluids, rest, isolation to prevent spread, rest, and perhaps anti-inflammatory agents such as ibuprofen, or Aleve, and such. Outpatients with mild to moderate risk symptoms and risk factors such as elderly patients, use of monoclonal antibodies, which have now been approved via the Emergency Usage Act of the FDA. You may recall that President Trump, when he was infected with SARS, received this. At that point in time, very few people had access to that, and it was very expensive, but it's now been made available. And actually, people are encouraged, if they have any symptoms and they have the risk factors, to receive the monoclonal antibody treatment promptly to reduce the risk of progressing. If patients have progressive symptoms and they are admitted for management, If they are without hypoxia, in other words, they have oxygen saturation of more than 94% on room air, then remdesivir, which is an antiviral medication that binds to the RNA polymerase, may be appropriate. Those with hypoxia requiring supplemental oxygen may have the same thing, plus the dexamethasone, which is a systemic anti-inflammatory agent, as you know. In patients with rapidly increasing oxygen need and systemic inflammation, will need systemic steroids, the antiviral medication, and also the medication which is antibody directed against interleukin-6 receptor to reduce the cytokine inflammatory triggering reaction of the immune system, to reduce the inflammatory response of the body, which is actually working against itself. Same thing is true for patients who are ICU and mechanically ventilated, and you also have probably heard that one of the tricks is to also turn patients prone, which is something we don't normally do in the ICU mechanically ventilated, but this is to help save their lungs. This is an area of controversy which you may hear about or may have heard about, and that is the recommendation by certain leaders, Bolsonaro of Brazil, by Trump in this country, for hydroxychloroquine, an anti-inflammatory agent, which has been used in, for instance, in rheumatoid arthritis, an antimalarial agent, and also ivermectin, which is an antiparasitic agent. There is a well-known physician, Robert McCullough in Texas, a professor of medicine at Baylor and at Texas A&M, who has argued with the FDA and the NIH, saying that both of these he has used in patients with moderate risk and elderly population, and has kept hundreds of patients out of the hospital and likely have survived because of his use of these. This is a very controversial area. The NIH expert panel has reviewed all of the studies on this and feels that this is not an area that they would recommend the medication. But this is an area that, as I said, truth will probably come out over the course of time as more studies are done, which should be done. And they are being looked at in other countries by very good physicians, including Italy and Brazil and other parts of the world. I would like to specifically address the role of leadership and lessons learned the hard way. Leadership is critical at all phases of the pandemic. We know that emergency preparedness for disease outbreak, surveillance, and containment through epidemiologic efforts is crucial. The prior administration in this country, the Obama administration, had an emergency preparedness office and provided guidebooks and information to the Trump team when they took over the office of presidents. And unfortunately, that office was closed. The Trump team felt that it was not relevant or needed, and unfortunately, that slowed everything down in terms of the ability to respond. Containment through epidemiologic efforts, as I said, for respiratory virus, mass physical distancing and isolation, contact tracing, and follow-up are things that are critically important. Another very important part of leadership is resource coordination and management. The issue of personal protective equipment, the testing capacity, developing the tests and expanding the tests quickly, the capacity for appropriate medication, the adequate number of ventilator and bed supplies, and access and distribution of those supplies, as well as the integrity of the supply chain and the funding and management of that supply chain. Unfortunately, there was a lot of chaos. Who was responsible? Who was in charge? Was it the federal government? Was it the state government? Was it the presidency? Was it the governors? And unfortunately, there was outbidding by different state agencies and the federal government for certain parts of these supply chains. Unfortunately, a number of the supply chain components were coming from abroad where we didn't have control over that. This was really a critical failure in leadership on a long-term basis. Unfortunately, too, there was the lack of consistent and coordinated messaging regarding the importance of these factors and lockdown if necessary. So we saw President Trump denying the need for social distancing, for masks, and for locking down if necessary. He argued, like many of the governors in certain states in this country, that the economic price was too much to pay. And unfortunately, what we have seen now is 600,000 people die, when if we had been more careful about this, we may have been able to save several 100,000 lives. That's not a small price. The need for worldwide vaccine to decrease is something that was important and really was not put onto a critical and coordinated plan until the very end of the Trump administration. I'd like to just review a couple of other issues here regarding controversies, and one is the origin of the COVID-2 origin. This is an interesting finding here. Since 1992, the virology community has known that one sure way to make a virus deadlier or gain of function research, which has been going on in the United States for over 30 years and other parts of the world, is to give it a furin cleavage site at the S1-S2 junction in the laboratory. When scientists want to create a particular gene sequence for a furin cleavage site in a virus, they invariably use the following sequence of amino acids, the CGG-CGG. There are 58 known viruses in the subgenus family, in which coronavirus is one, and among there are 580,000 such 6-letter sequences. However, there's only one of the 58 SARS-CoV-2 has the CGG-CGG sequence, the only one, which means that's the only one that would be able to have the furin cleavage site, which is where you could insert portions of a gene to affect its function. In other words, we would expect to see this kind of thing in nature, but of the 58 known viruses with 580,000 6-letter sequences, none except the COVID SARS-2 virus has that site where you could put in that cleavage site, the cleavage site location, which means in all likelihood that it probably didn't come from nature if we believe this data. Neither the pangolin nor bat coronavirus, which have been mentioned as possible natural reservoirs, have the furin cleavage site. And there are some who have argued that portions of the gene has sequences which look similar to certain other viruses, including HIV and some other genomes. This is something that's controversial, that has not been completely proven. The President of the United States, President Biden, asked the U.S. intelligence community to redouble its efforts to determine whether or not there may have been an accident at the Wuhan Institute for Virology, and whether or not this was perhaps a gain in function creation that somehow got outside the lab and infected people in the area. It should be known, too, that the United States has funded this research in China at Wuhan, as well as in North Carolina, and that the woman who was in charge of the lab in Wuhan did a fellowship with the gentleman in North Carolina who's been doing this research for close to 30 years, and that Dr. Fauci was not only familiar with this research, but helped support and fund it, with the idea that gain in function work would allow us to be able to anticipate possible pandemics going forward. That's the logic, or at least the rationale that's been given. So let me end here with the controversies that surround now the vaccine, which is something that has been discussed. The traditional vaccine approaches have been tested over decades. The technology is well understood with very low complication rates. The new mRNA technology utilized the generation of a viral protein to stimulate host antibody response. Both Pfizer and Moderna vaccines using the mRNA technology were given emergency use approval by the FDA despite limited follow-up, with the primary measure of effectiveness as preventing death from COVID-2. The mRNA vaccines trigger inflammatory myocarditis in a small percentage of 12 to 17-year-old patients, supposedly reported to be self-limiting, although quite frightening for those who have experienced it, and it's in the range of several thousand patients. There have been reports that deaths have occurred from the vaccine, but this is something that has not been either confirmed or denied by the companies or by the FDA. The spike protein, which is the protein that's used in the mRNA vaccine, appears to be the primary cause of immune reaction in many patients, and there are a number of people who have raised the question of its safety using that. There is a conference that was was put on in Great Barrington in Massachusetts, called the Great Barrington Accord, supposedly arguing for natural herd immunity and immunization only of those people who are at high risk. Curiously enough, they claim at least 150,000 scientists around the world having signed this, but if you look at the details, many of these people are not scientists, and many of these are false signatures. Interestingly enough, the Great Barrington Accord seems to be backed by the American Institute for Economic Research, and that is a conservative think tank, if you would, sponsored by the Koch brothers, who are billionaires who believe that the economy has been unfortunately affected by the pandemic, and feel strongly that we do not to wait any longer to open up the economy. So this is a controversy. The question is, where are we with our belief of what's true? And I can only ask you to reflect on what you've been told, what you've heard, what you've read. And I'm going to ask you to be thoughtful about, when you listen to the sound bites, particularly that come from different social media, that they are not necessarily the full report, and that you need to think of what biases are there, what the agenda of the reporting agency is, as well as who's doing the work, whether there are political factors, economic factors, particular social factors that are there, and also recognize that over the course of time, most science will be proven through multiple testing, and we will learn the truth over the course of time. And so, as I said, time and truth will meet on the horizon, but we are in a perilous time now where we are not sure what to trust. And this goes to the point of whether or not we send our children back to school, vaccinated or not vaccinated. Is it safe to vaccinate them? Is it safe to have them go to school without masks or not? Are they transmitters of the virus, or are they just at risk for a virus in a small percentage? What about families who have loved ones who are in the caring fields and who aren't able to isolate? What about those people who are unable to afford the care they need? We have many issues, and I'm hoping that all of this work will bring about a change in the way that we offer healthcare in this country, and also in the way that we recognize that we are part of the world health environment, and that we cannot just vaccinate and isolate like some countries are trying to do, for example, Australia. I hope this has stimulated some thoughts, some interests, some questions, and some reflection. I look forward to seeing you at the roundtable. Thank you.